When you look at 3 years from now, with as much investment in AI and automation in this space, what do you think of them today?
Operationalizing AI. Operationalizing AI is that's the only reason why we're not seeing AI deliver anywhere close to the growth that was to deliver. We're not even seeing 1 to 2% lift right now across healthcare PE. And the reason is we're just enamored by all these fancy things that are coming across, but to be able to really put that in the workflow and operationalize it and get people to drink the Kool-Aid and make the necessary changes in the organization that drives organizational performance, that is what's needed over the next 3 years. And a lot of these people that are going to come out who have raised a lot of capital in the meantime, because AI is a big hype right now, will kind of whittle away, because if you don't see the results, what's the point?
All right, welcome to the next episode of the Scale Community Technology and Innovation Podcast, where I'm joined today by Amol Nirgudkar, the founder and CEO of Patient Prism. Amol, welcome. I'm excited to have this discussion today.
Thank you for having me.
So, just at a high level, Patient Prism leverages AI to bring analytics to voice phone conversations between call center employees and patients. So, taking amorphous conversations and turning them into more data-driven, actionable insights and intelligence on how those calls went, what could be done better, where the opportunities lie, and how to improve patient service. And so this is a pain point for a lot of organizations. There's a lot of value lost in these phone calls. There's a lot of customer service that could be improved in these phone calls, and it's a very difficult thing to get right and to standardize across an organization. So on its surface, bringing data-driven analytical intelligence and clarity to that sounds very relevant to improving the holistic patient experience for the company and for the patient. But Amal, if you could introduce us to Patient Prism and do a better job than I'm doing to explain what it is that you set out to solve for, what it is that Patient Prism is offering, that would be great.
Yeah, thank you for again having me. We started in the AI business 10 years ago, 2015, when Alexa and Siri had just launched. And our initial hypothesis was that patients were calling call centers or even clinics, right? And somehow half of them were not scheduling an appointment. And this was initially in the dental world. Now we broadly serve overall healthcare. And our hypothesis was like, hey, there is the receptionist or the call center agent maybe fumbling the ball, maybe not having a sales conversation that gets the patient to do the next step, which is book an appointment. And we wanted to understand why patients were not booking appointments. So the birth of Patient Prism was to solve that problem. How can we get more patients to book more appointments? Period. Right. So at the time, natural language processing was the right vehicle to use, right modality to use in AI to kind of understand who called, why did they call, what do they want, did they book or not. Eventually, the evolution of AI went from that to kind of neural networks, where we kind of train the AI to understand context of a conversation and dig deeper into that insight beyond whether the call booked or not booked. And then eventually the advent of large language models allowed us to even dig deeper into contextually what is going on. And when you combined NLP, neural networks, language models, and we now figured out after 8 years in the business, now this is our 10th year, is that the ability of a patient to book an appointment has to do with three things. One of them was the initial hypothesis, is the receptionist's ability to have a sales type conversation. But the other thing also is predicated on the fact that, was it actually a good lead in the first place? Did marketing drive the right patient for us to close them? If they didn't, right? And assuming there is a B2C component here, in dentistry, there is quite a bit. In many other healthcare verticals, it's there. Did we have the right person? Did they have the right insurance? Were they the right lead? And so that was a part what Patient Prism looked at. We built integrations with marketing platforms to understand lead quality and lead quantity, so that we didn't just blame the receptionist or the call center agent for an appointment that couldn't have been scheduled. But then the third part of what Patient Prism does today as well was the third part of the Venn diagram, which is it was a marketing component, there's a sales component at the call center, but there is an operations component to it, which means What if we drove the best lead call and our agent did the best job they could to schedule that? But what if we don't have capacity to put them anywhere? What if we don't have the providers to put them anywhere? What if we don't take their insurance? What if we don't have ability for the patient to afford treatment? What if the service is not available? And so we trained AI, conversational AI, to identify the reason why and find those needles in haystacks. Is it a marketing problem? Is it a sales problem? Is it an ops problem? And then deliver those insights to the right people in the organization so they can make the right decisions about why our patient flow is not what it's supposed to be, which means it's not driving the highest amount of revenue per hour per provider we have to drive the best same store growth and EBITDA margin expansion. So sorry about that long
No,
winded explanation.
there's a lot in it, and I want so you've got the sales, marketing, and then also physical footprint, facility utilization, provider utilization. So
Absolutely.
you cover strategy, sales and marketing, analytics, and operations. So let's unpack some of that and actually get into the details about how a client uses Patient
Yeah.
Prism. So on the front end implementation, is a company confirming their strategy for which patients they want to go after, and you're tailoring the AI to learn what the criteria is for vetting patients? And then how is the call center team, how is the management of the organization using Patient Prism thereafter?
Well, there's a couple of ways to implement it. One way is to track new patient. New patients are important, right? Because they spend more money. Their contribution to same store growth is higher than existing patients, presumably, and they're more profitable because once you've met fixed costs, it's all the margin's pretty high. So new patients are kind of lifeblood of really making sure they're driving a healthy amount of same store growth. Now, if you want to track new patient conversions, you want to put Patient Prism tracking numbers on websites, on Google My Business, on ad extensions, and see what kind of traffic, new patient traffic these mediums are driving. So that's one. And then when you have that, when patients call those numbers, we send them back to the call center. And that's how we capture not only the conversation, but also the customer's journey until the point they made the phone call, right? And that's important. So that's one implementation. The other implementation is if you just want to do call center optimization, you can put us directly in your VoIP platform and send us those phone calls and we can analyze them. But then it doesn't give us the marketing insights, which are equally important, right? Because if you are a B2C provider, you need to do both, right? You need to do the marketing insights and what's happening on the phones from people directly dialing the entity. But if you are just everything you get is you don't do zero marketing, then you implement us directly in the call center through the telephone system and see where that is. So that's the first part. That's the implementation.
And what are the outputs? What do the insights look like that you wouldn't otherwise get to without the Patient Prism solution?
Yeah, on the marketing side, you get to understand the number of marketing qualified leads that were actual leads that called and that actually booked an appointment. There is a huge challenge in marketing metrics where you think marketing lead is a conversion, which what Google calls a conversion is any call lasting 20 seconds or 30 seconds, whatever that's configurable. But not every call is a lead. It's not
Mm.
every person, and it could be anybody. Anybody goes to the website, calls the number. That doesn't mean that. So validation of lead is the first thing we do. Is it an actual lead? And the second thing it does, which is very unique to us, is understanding the type of lead it was by the industry that you are serving. So in dentistry, whether they want hygiene, they want orthodontic, they want implants. In physical therapy, where they're from surgery, where they had back pain, they had auto injuries. So segmenting leads is super important because we want to know, are we driving good quality leads that have a higher lifetime value? Or are we just driving leads? And in healthcare, like in everything else, not every customer spends the same amount of money with you.
So
So if I go ahead.
when you think about all the different channels that these MSOs, these DSOs have for direct to patient marketing, Instagram, Google, Facebook, the list goes on, traditional media, whether it's TV or radio. What are some of the key takeaways that have come from using Patient Prism in terms of which channels are the most effective, in terms of which marketing strategies are the most effective? What are the best practice lessons learned that have come from bringing a much more analytical view to this
I think
part of the patient funnel?
It's a great question. The first thing you have to measure what channel is driving how many leads and what kind of leads. Super important. You have to know Meta, which is Instagram or Facebook, will be these many. Let's say you're a plastic surgeon and you're trying to do a breast augmentation campaign. And let's say you're doing that. And so, okay, well, I spent $2,000 on Meta. It drove me 12 inquiries on people who wanted breast augmentation. Out of those 12 inquiries, 8 of them booked an appointment. And eventually, what happened to them? So you need to understand the quantity of leads and the quality of leads by channel. And Patient Prism provides that on a platter in real time. Now, the other thing we do on a marketing standpoint, we actually take that booked appointment, we notify Google, Meta, or Bing in the digital space that, hey, Google ads, this is a good marketing qualified lead. So go optimize your ads based on this persona, right? And this persona is important. So what ends up happening is now we're sending good signals back to the ad platforms. The ad platforms are now using those signals to auto optimize their algorithms to show the right ads to the right people based on the lookalike stuff that they do. And it eventually reduces your cost of acquisition. So that's the marketing piece Patient Prism is really, really deep into to making sure, let's figure out first before they even call, are they of the right kind? Are they in the right amount? And are we spending the right amount of money driving them in?
So it sounds like Patient Prism brings a more scientific approach to iterating on your marketing strategy. So you can see what's working from a data-driven perspective, and then you can do more of that or replicate that. But
100%.
it doesn't sound like there's any hard and fast rules that Facebook is better than Google, or digital ads are better than SEO or things of that nature. It sounds like it still is, from a company marketing perspective, a bit of a guess and check about what's resonating with which market and why.
You bring up a great point. Nobody knows what is the right solution. It sometimes depends on the geography you're in. Certain geographies, some things work, but sometimes it depends on your place in the market. You have 500 Google reviews, you're going to be showing up organically pretty high on the listing. So it's a combination of test and trying. And part of what we do as part of our monthly analysis is we tell them, hey, this is what's working, this is not what working, it's driving this, do we want to try that? And work with the agency partners and the CMO or the VP of marketing to make sure that all channels are optimized. If certain channel is not working, we have to make a decision. Do we spend more money here, or do we allocate money to a different channel that's driving more qualified leads? So that there's no set and forget anymore. You've got to keep hustling for good patients at a lower cost every single month. And part of what we do with our clients is that conversation.
So that's on the very tip of the funnel in terms of generating leads, which
Correct.
channel, which message is resonating. Now let's
Correct.
go one step further on the funnel and talk about that conversion process. So two questions come. One is a similar question on best practice, and what are the key findings on what is generating a high conversion rate versus not?
Great.
And then two, it sounds like a big part of that is qualifying these leads and determining which are worthwhile leads versus not the right fit. And I'm just wondering if there's any solution to that inefficiency, that waste of time on these lower quality leads that weren't real candidates for your service to begin with.
Well, if they were lower quality leads, I can talk about them later. We just have to tell the marketing agency partner, like, hey, we need better leads, and we can automatically unweight them. If we can't, like, for example, you didn't take Medicaid and all these leads were Medicaid, you can automatically unweight them so they don't mess up the data the dashboard that you see Patient Prism. You only see qualified leads, because you can't judge somebody for not booking somebody you couldn't have booked anyway, right?
Mm-hmm.
That's not right. So you have the ability to unweight those calls that you are not going to take anyway. Now, when it comes to receptionists, we developed this 14-point rubric that we have the AI analyze every single agent. We use something called voice fingerprint to analyze who picked up the phone without them saying the word. So as soon as said, well, this is Jason Schifman, and Jason answered the call based on his voice fingerprint that we had enrolled in initially. So even if there was 5 Jasons in the call center,
Mm-hmm.
we knew which Jason picked up the phone. The second thing we do is we have this 14-point scale that we said, okay, well, and part of the 14-point scale is, did you answer the phone correctly? Were you enthusiastic? Did you actively listen? Did you offer them? So there's 14 things that we measure, Jason, on did you do those things correctly? And what we found out after the first 50 million phone calls, if you did 80% of those things correctly, the probability of you booking an appointment was 80%, provided you had capacity. So we did this big statistical model. This was 4 years ago. And we said, because at the end of the day, patient doesn't know how good you are clinically. The patient only knows how you make them feel. And how you make them feel has to do everything with soft skills and not clinical skills. And so we built a rubric that allowed us to evaluate every agent, not only whether they booked the appointment or not, but also on those 14-point inspection on what are the best practices to do. Don't interrupt the patient. Offer them an appointment. Make a strong effort. Offer them financing when it's needed. Have a clear, well-spoken greeting.
So
Express
these
empathy.
14 points are fairly standardized across all practices, all specialties. It's not as if it's changing based on where adult versus pediatric, where commercial versus Medicaid.
Now, our clients have the ability to tweak those things. If they have a special approach of doing QA, and they said, "Oh, in our clinics, we like to do family appointments, and we want we want you to analyze whether every agent offers multiple appointments on that call for the whole family," and that's something that we have trained our people to do. So now, if they want to change the rubric a little bit more, add or subtract what they don't, they can add that. And so we can measure that. Jason, you only offer multiple appointments 30% of time. You need to do a better job at that because, once the whole family comes in, our average revenue per visit goes up and we're optimizing that better. So yes, you can do that. So that's the sales process. So every agent like you, let's say you're the agent, you have a report card built on how you're adhering, not only a report card based on how effective you are at closing, but if you also gives you a report card on those 14 variables on how you're adhering to them. We call them call basics. And so I can just tell you, Jason, by the end of the month, if you're scheduling only 60%, I said, Jason, if you want to go to the next level, you got to work on these 4 things, right? Mm-hmm. Number 1, you can't interrupt the patient. Number 2, if the patient wants high value services, you want to offer them financing options. Number 3, you've got to make a strong effort to book an appointment and not just say, okay, thank you very much, bye-bye, right? So those are the things that we can now coach you and tell you this is what it is. And then the call center managers can go on the program and say, teach them this. And that way they can become better versions of themselves and doing that better. So that's the second part. Marketing was the first part. Sales optimization, sales enablement was the second part.
And the third part?
The third part is operations, and it's really the most exciting part. So if you want to know a statistic that since COVID, since 2021, all of healthcare, 40% of patients don't book an appointment because operationally we just don't know what to do with them. What I mean by that, operationally isn't either we don't have capacity to put them when they want an appointment. A new patient calls, for example, and they're looking to get a service, and you don't have an appointment for 4 weeks. They're going to call the next person, right? Nobody wants to wait anymore. So operationally, what I mean, capacity is 1. 2 is insurance is a big part. If you don't take their insurance, what do you do, right? What kind of conversations can you have? The third thing is pricing. What if they can't afford it? What if you're fee for service? Then how do you pricing objections? Sometimes you have service unavailable and language barrier, and those are some of the things. So when you look at the totality, these 5 or 6 things, we call them operational barriers, and can be equally are responsible for 40% of appointments not booked. So then what we have to do is we can say, the Orlando office could not schedule 30 patients last month because we couldn't offer them an appointment when they wanted it. So we don't have a demand generation problem. We have a supply problem. And the supply problem is we need more providers, right? We need more nurses. We need more doctors, whatever that is, right? And so unless we figure that out, let's take the marketing budget from Orlando and put it in Memphis, because Memphis needs more leads, and they need more leads. And just because the CFO said we need to spend 3% in marketing, we could take 2% from Orlando, put that in Memphis, and maybe Memphis is at 5%. That's how you do. You decide marketing budgets based on available capacity and provider availability, and not by some rubric. Oh, it's 3%.
Yep. So your leads, so marketing, sales, operations, you bring analytical clarity to that life cycle, quality of leads, conversion of leads, and reasons why the non-converting patients are not converting, whether it's a sales rep or the operations. In terms of the improvement, so the recommendations, the strategy, the changes based on the findings from the analytics, is Patient Prism getting into making those recommendations proactively to the marketing managers, or is it incumbent upon the marketing manager and the executive leadership to look at the data and draw their own conclusions about how to drive better results going forward?
No, actually, every quarter for our larger enterprise clients, we prepare what we call like a management consulting report, where there's recommendations for marketing, there's recommendations for the CMO, the VP of marketing, and the agency partner. Here's what we recommend you guys do. Then there's recommendations for the COO and the VP of Ops and the regional manager of operations on what we think you guys should be doing, where the opportunities. There's recommendations for the call center managers on missed calls and all that stuff. There's recommendations for the clinical team on expanding capacity and everything else. So there is a 10 to 15 page document accompanied by a 10 deck slide that goes every quarter to the executive team on Patient Prism. Okay, here's all the data. It looks pretty. This is all the AI. But okay, well, what do we do with it? And how do we quantify the opportunity? So one of the things we do is cohort analysis. We look at the top 20% of performing clinics, bottom 20%, and the middle, right? And we look at all the metadata across all these different things: segmentation, lead generation, number of leads, closing rates, insurance obstacles. We look at all that across the different cohorts: the top 20 cohort, the bottom 20 cohort, maybe the overall cohort, and maybe the middle. And what it does, and then we have, using our own proprietary AI, we say, all right, well, what does this mean? Well, what does this mean? For example, I'll give you an insight that'll be one of your QBR type reports. Well, the top 20%, the the patients who say no because of insurance is only 30%. The bottom 20% cohort, the patients who say no because of insurance is 65%.
Mm-hmm.
Well, is it a in-network problem, or is it just we don't know we're in a network, right? And so that starts the process of figuring out whether why the top 30 offices are able to have better, top 30% or top 20% of the offices are having better insurance conversations versus the bottom 20%. And now this becomes even more relevant when you are a decentralized platform. You don't have call centers because there's turnover at the front. People don't know all the insurances they take. Like Medicare Advantage plans, for example, have been doing amazing in dentistry over the last 2 years. Half the industry doesn't even know they take. So that is part of what I want to really emphasize, Jason, is AI for the sake of AI and these vanity metrics and this wonderful chat GPT based bright, shiny objects don't move the needle for these organizations. What we have to do is translate the AI into actionable steps for everybody in the organizations so they can do, if I do this, if my bottom 20% offices match the top booking rate and match the total number of leads at the top 20, I can add $7 million to the top line over the next 6 months.
We'll come back to some of those other solutions in a second, but I want to also talk about some other variables. And when I think about the conversion cycle, so there's how much did I spend on these different channels, and usually that would be housed in a finance and accounting system. How much did I spend on Google ads versus Facebook ads versus Instagram? There is what procedures and services did these patients ultimately consume? Did they come in for an initial consult? Did they have follow-on procedures? Were they high quality patients, right? Did they stay with the practice over time, or did they just come once? And then what's ultimately the lifetime value of that patient? So does Patient Prism also get into that holistic ROI assessment from a cost to lifetime value and patient retention, or are you primarily focused on assessing the front end of the funnel from leads to conversion?
Great question. Until now, we have been only on the front end. We just finished all the integrations in dentistry, and we're also doing some stuff in medical like Epic and Cerner and all that. We want to connect the dots, right? Click to production, like to what the LTV was, because you want to know what those averages are. And in the SaaS world, those are very important. LTV to CAC. In healthcare, I think it's important. So it's a big initiative we're actually piloting with several hundred clinics where we kind of provide information. Did they show up? Number one, they booked appointment. Did they show up? And how much did they end up spending? And that's important to know so that we know where to spend or allocate our
So
resources.
that brings you into EMR integrations. It sounds like you're doing in the dental world. Is that fair?
Dentistry is all finished. The integrations are done, and we're right now aggressively in the medical world. We're getting integrated with everybody else because people want to know the whole journey.
One question that kind of bridges us back to some of those other solutions is Patient Prism mostly a retroactive assessment to drive performance improvement based on what's happened? So you mentioned the quarterly review. Is there any component that is real time? While an agent's on the phone, this is intelligence that agent needs to know on his or her performance or on the patient to drive a better outcome.
So yes and no. No, I'll answer no first. Is from a call analysis standpoint, within 20 seconds of a patient hanging up the phone, our analysis goes to somebody at the call center saying, you lost. The patient wanted to spend money on a tummy tuck. They were worth tummy tucks are $8,000. Here's what happened. Here's what you didn't do. Go connect with that patient right away. So that we call that reload, re-engage lost opportunity. That happens within 20 seconds. We can't do it real time because sometimes the context it gets missed in real time. You could have a terrible conversations and the patient still books an appointment. So you can't know until that eventually the call ends what ended up happening. And based on that, you can design an intervention. So it's hard to do this real time. Within 20 seconds, and what we've seen across the board, almost 20 to 25% of those patients are coming back on that second attempt. When we send the alert, you lost the patient tummy tuck 7,000. Here's what happened. Call the patient back. 20% of the time, they're coming back. So that's a big revenue recovery piece, which we pioneered this concept in healthcare of recovering revenue we just lost. Item number one. Item number two, we're launching, we've been in testing with AI agents for the last year. They're not good yet. They look good in demos. A lot of folks have, it's easy to make an agent today. All you do is put ChatGPT behind something and you have an agent. That's not how you do it, right? And where we've been aggressively testing a lot of AI voice agents to make sure, number one, the latency factor is taken into account. Number two, they have full context of that office and how they schedule. And what we're doing, at least in dentistry with the agent, is we're allowing the agent to actually book the appointment directly into the practice management system based on what the patient wanted. So that is coming. In my view, if I had a prediction, by the end of this year, we think we can abstract away 20% of phone calls by an AI agent for lower end services, right? Not high acuity. I think by end of 2026, we'll see 40% of healthcare calls handled by AI agents, and then it'll keep improving from that point onwards. So those are the
I was
two
going to
answers
ask
for you.
because a lot of automation is a buzzword. AI is a buzzword. AI agents, and so I think the common pushback would be this makes a lot of sense in terms of applying analytics to an otherwise amorphous task like call center, like phone conversations. And so that sounds wonderful, but I'd much rather remove the people element altogether. And I think your response to that, it sounds like, is that that's good in theory, but today the market can only handle 20% of the calls at best using automated non-people solutions. Is that fair?
Yeah, I think rigorous testing needs to be done on patient abandonment rates on using AI. Rigorous testing needs to be done in making sure that the AI is not hallucinating and providing wrong information to, especially in certain like behavioral health. You have to be very careful on what you tell the patient. And if an AI agent is being deployed, it better not give advice that could lead to adverse outcomes. In some other spaces, it doesn't matter, like in the medical spa context. So it's really important for the patient experience not to get diminished. And AI agents have to do a much better job at understanding that this is still a sacred conversation in healthcare, right? The patient is coming there to give you the trust. And if you break the trust by doing something silly, which is like, then it's not good. So that's where our approach in the AI agent world is going to be. We're going to test the waters. We're going to crawl, 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 crawl. Then we'll start walking a little bit for a little while. And then hopefully we'll run one day. We may not. We may not run one day. It may not be as easy as an open table appointment on a restaurant or a haircut appointment. That's much easy. It's super low acuity. Doesn't matter. It's not a complex conversation.
Well, we take a similar approach, and I think that we are migrating from the services and the analytics side into the automation world. And I think at least we like to believe that that's an advantage relative to somebody coming at it from purely a technology standpoint. That sort of migration feels more organic and feels more aligned with where the market is today. Question I have is from rolling out. You mentioned 20%, so let's roll with those numbers. 20% by end of 26, or end of 25, 40% by end of 26. How do you roll out, practically speaking, an automation solution that can only handle 1 to 2 out of every 5 calls? It feels like that would lead to, in some ways, a degradation in the patient experience because I first have to go through an automated solution only to find out that I need to be sent back to a person.
Here's the thing, right? 20 to 25% of phone calls are not answered during business hours by people. So that's the first step. Right? You take all the people that are not even answers. 20 to 30% missed call rate, that's what you abstract away. Or after hours, weekends, you do that first. Once that's done, then you decide, maybe there is a ring sequence. If nobody picks up the phone after 3 rings, the agent picks it up, or 4 rings, whatever your sequence is, so that it doesn't go in the first place to an auto attendant or a voicemail. That's, I think, 2025's goal for us. I don't want to take away calls from agents until we have solved that. And once we solve that, next year, we start with simple appointments. Like in the dental world, it's just a hygiene exam, routine hygiene exam. In the internal medicine world, it could be just an annual visit, right? Well, in OBGYN context, it could be woman visit. Okay, not much, simple stuff. You know what the appointment slots available are. The agent can provide those slots and get it done. The key in all this, one of the things, our approach to this is, we're not going to put all our eggs in the voice agent basket. We're going to have the agent for voice, we're going to have an agent for text, we're going to have an agent for chat. And all of them will, and then there'll be an orchestrator agent, depending on what the patient wants. Patient wants to text and book an appointment. Well, let's engage them over text. Patient wants to chat on the web widget. Let them chat. And I think so. We have to think about that. I think texting could be a great mechanism, although, people love to text and that could be easy. But sometimes the conversations get a little complex. And
when you look out over the next couple of years, let's say 3 years from now, with as much investment in AI and automation in this space, with as much competition, what do you think the winning service providers will look like in the market 3 years from now? And what do you think relative to the way we're thinking about it today, the technology and capabilities that will be commoditized 3 years from now that won't be as valuable as the way we think of them today?
Absolutely. That's a great question. I think there's 2 concepts here. One is, are you a feature or a product? Right? If you're just a feature, like I remember Apple used to have like 3 years ago, we used to have a flashlight app. And eventually Apple built that in, and then the flashlight app companies, that was just a feature. So a lot of the AI companies that lead with, look at, I got call summaries, wonderful, right? Call summarization, wonderful. And if I've got one voice AI agent, now if it's just one feature related, you're always going to have somebody else build a better feature, and it's cheaper and faster, right? So that's going to be super important. And what I mean by a product versus a feature, it supports the organization in meeting its goals, right? And the product has to have a little more substance than just one little trick pony. Consolidation of the stack is going to be important, and in a product, AI product of the future must solve multiple problems in the organization and support multiple people in the organization to achieve whatever objectives they are, whether OKRs, MBOs, whatever they are, they're using. Organizations that focus on that, moving the needle by partnering your analytics with the people and driving change management in the organization to move the needle to whatever they're trying to do. Same store growth, 8%. Okay, well, how are we getting there? What AI vendors and partners are we going to deploy in getting us to 8% same store growth? Now, not everything cannot be AI vendors. Sometimes you have to have operational things. Those are the guys that focus building products, not features, that lead with change management, that lead with operationalizing AI. Operationalizing AI that's the only reason why we're not seeing AI deliver anywhere close to the growth that it's supposed to deliver. We're not even seeing 1 to 2% lift right now across healthcare PE. And the reason is we're just enamored by all these fancy things that are coming across. Oh my God, look at this. I can create images. But to be able to really put that in the workflow and operationalize it and get people to drink the Kool-Aid and make the necessary changes in the organization that drives organizational performance, that is what's needed over the next 3 years. And a lot of these people that are going to come out who have raised a lot of capital in the meantime, because AI is a big hype right now, will kind of whittle away, because if you don't see the results, what's the point?
Well, it's a good point, and I want to go back to the flashlight comment for a second. I mean, the flashlight app was a product until it became a feature. It got subsumed into the phone, and so I view that as point solutions make sense until they're easily integrated, and so that was a case where it was easily integrated. When you think about the point solutions in this market, there's analytics applied to phone calls. There is LLM applied to, and AI agents applied to scheduling. There are CRMs for managing the outbound patient engagement, as well as the lead intake from an analytical and infrastructure perspective. There's the call center software for managing the phone calls that has some basic analytics attached to it. So is there an obvious consolidator out of all of these point solutions, or are they all equal? Or are we going to see sort of some of these point solutions prevail and sustain, and it's not going to be as integrated as we might ideally hope for?
It's an amazing question. Consolidation of the tech stack needs to happen. We can't have 19 solutions. First of all, you can't afford it. Number two, nobody uses it if there's too many. So part of what we're doing in Patient Prism, we're launching a CRM so that we can do the whole patient acquisition, engagement, nurturing, reappointment, the whole thing, whole 9 yards. So we are trying to help, and the agent will come part of that, texting, all that stuff. We want, for example, our mandate is we want to be the patient, the lead management platform. Lead management from start to finish and reappointment, the whole thing, right? It's always a lead. And we want to encompass everything that's part of lead management. We want to build in house so that our clients don't need 5 solutions. They can just come to Patient Prism and say, all right, Amol, you help with marketing attribution, you work with call tracking, you work with sales enablement, you work with operations enablement, you do my nurturing of leads, you do reputation management one day maybe, you have AI agents. Now I can pay a fee to just you and actually just train my people on this one solution that does solve 5 problems. Right now I have 5 solutions, and you're doing them at a much cost effective rate, because for me, an added solution is a feature, part of my product. It's not my entire product. So I can offer them a much better price for the same or better level of service. So stack consolidation is a must.
It sounds like you built your roots in the DSO market, and on some of the new functionality that you're incorporating, like integration to the EMR, you're also advancing that in the DSO market first. But I know you've also expanded to other markets. So just to tie that back to the question of winning in the market and competitive differentiation, do you think that it's better to stay narrowly focused on DSO and build out this better than CRM with integrated analytics, AI, automation technology, but narrowly focus on the DSO needs in the DSO market? Or are you going to continue to pursue the broader approach and apply it to the medical world as well?
We're actively in 10 other verticals outside of dental. As long as there's the same problems, and they seem to have the same problems everywhere. People are people, they're answering the phone calls the way they are, and they don't know. I think as long as we can provide good actionable insights to any industry. Now, there might be some industries within medicine that, like cardiology, for example, we may not have a use case because, there's only a few cardiologists, there's plenty of patients, whatever that might be. And I don't know until we kind of get into it. But based on the 10 verticals we're in, we are providing deep insights, even if it's not fully baked in with EHR integrations and everything else. There's enough meat on the bone here to improve lead acquisition, customer acquisition, patient acquisition, reduce customer acquisition cost, all that. And then as we get our approaches, as we get larger and larger clients in these verticals, we're open API kind of philosophy. We'll connect with anybody who gives us API access, and integrations are easy to build. For the most part, you can build one in 3 to 4 weeks. So it's a big enough use case. The good news, what we've done is we've built the foundational architecture to connect with any EHR. So all the logic is the same, whether it's dental, veterinary, optometry, plastic surgery. It just the access to the EMR becomes sometimes the choke point, depending on what endpoints you have access to, depending on read, write, whatever they're giving you access to. So it would be very, very easy for us to take 90% of our infrastructure and overlay that on another EMR for another industry. But the AI is smart enough today to adapt to an industry, and we are built this DNA of asking our clients, what other context do you want us to train the AI in, so that it provides you a more nuanced approach to finding needles in haystacks. And that's what it's all about. If we can't
Yep.
find the needles.
I was listening to a podcast this weekend, another technology solution in the healthcare market, and the CEO said that the key to effective growth and sales in this market from a technology perspective is to perfect attribution. So the buyer, the CEOs of the provider organizations, they want to know that the incremental technology that they're paying for is the driver of the incremental change and performance improvement that they're seeing, rather than, yes, you can point out that there is performance improvement, but I'm not really sure that that technology really caused that positive change. How is Patient Prism making it easier for your clients to understand the specific results and value created by Patient Prism versus other random events across the organization?
I mean, I think the easiest way to our clients have seen ROI. Our ROI ranges from 15 to 45x within the first 90 days, right? Pretty high ROI. That's only coming from the revenue recovery piece, that we're able to send an alert, they call the patient, they recover back. And a lot of our private equity backed groups, they're very analytical. And sometimes the operating partners of these PE firms are actually going in and saying, okay, well, Patient Prism was responsible for so many recoveries. Let's go in the database. So we're able to ship some of our data into a data warehouse where they can resolve and adjudicate the revenue earned from all that stuff. And that's where the ROI comes from. So that's one piece of it.
Yeah,
The
actually
other,
interesting, because it's a similar concept to what this other CEO said. They waited on the failed outcomes to then recover. It was in a very different context, but it's a similar concept of avoiding the confusion or ambiguity over who's doing what, because you've waited for the other activity to play out, and you're there to clean up what's already been touched by others in the organization.
Absolutely. The other part is we don't know. I mean, we anecdotally are told that, hey, our marketing acquisition cost went down by so much because of Patient Prism. They don't know how to track that, but they saw empirically that, hey, it went down. We produce capacity. For example, one of our clients launched after they figured out that almost 30% of their patients couldn't come in because of capacity. They launched an initiative called proximity scheduling, and they had high density in certain markets. So what they did is, if a new patient called, they put them in another office that was owned by the same DSO. And that resulted in extra 1,000 patients a month coming in. And that there is a value associated with that, right? But let me just, I know we're towards the end of it, but attribution in the business world has always been thought of as marketing attribution. In my view, it's a very myopic view of the word attribution. Attribution could be marketing, attribution could be sales, attribution could be operations. And we have to really attribute a failure. A failure is a patient not booking an appointment in our world, right? We have to attribute it to the right reason. And sometimes it's like all we want to blame is marketing. That's not true. Sometimes marketing is driving the entire organization in a way where we think marketing is everything. It's not. It's not. As I said earlier in the podcast, where it could be the sales process, it could be the ops process. Marketing is probably responsible for only 30% of your growth. The 70% comes from your sales and ops. And so a lot of times I get very sometimes peeved at the whole organization only looking at marketing metrics as the end all be all for growth in the organization, when 70% of it nothing to do with marketing.
Amal, I want to thank you so much for the time and the insightful discussion. There's so much going on in this portion of the market around patient engagement, and I really appreciated hearing how Patient Prism has and continues to address this in a unique way. So thank you so much.
I appreciate very much. This was a fantastic. I really enjoyed this interview, actually.
Very good. Glad to hear. Thanks so much.